Well, hello everybody. I'm Justin Denholm from the Victorian Tuberculosis program, and really pleased to have the chance to say a few words about MDR TB in Australia as part of this session this morning. I say really pleased, but to be honest, I feel like it's a little bit of a poison chalice, because when I look at everyone else who's speaking in this session talking about MSF and the situation in Papua New Guinea, when I think about MDR TB in Australia, this is very much what I'm feeling like. Nonetheless, come with me, because I think that there's some value for us in understanding MDR TB epidemiology and management in a variety of different settings, including our own, and hopefully some opportunities that we have in low incidence TB settings to be able to focus in closely and do what we can to work towards optimizing management of MDR TB together. So let me start with what is unfortunately the most recent comprehensive review of MDR TB in Australia, which was a nice paper that Josh Francis coordinated some years ago, looking at a 15-year history of the MDR TB experience in Australia. Now, this is something that the National TB Advisory Committee coordinated as an interjurisdictional review, the idea being to draw together all of the state and territory-based data, particularly focusing on the lab-confirmed notifications of MDR TB, and thinking about the diagnosis and management and outcomes from those cases. And over that period of time, I'll foreshadow the fact that, first of all, we did see a general increase in absolute numbers of MDR TB over that period of time, at least in terms of diagnosed cases. And as you can see from this graph here, a pretty significant proportion, particularly in the second half of this period, around cases of MDR TB diagnosed in a cross-border management from PNG. Overall, this represents about 1.5% of all TB cases that were diagnosed in Australia over this period of time. Relatively similar in some ways in terms of our drug-sensitive TB demography, so about 50-50 male-female and a median age of 31. Quite different in terms of what we'd think now of as common countries of birth. So particularly, again, as I said, nearly a third born in Papua New Guinea, and then a more familiar Australian demographic beyond that. So next most common being people who were born in India and Vietnam, respectively. 3.7% HIV co-infection, and data that we don't have may also be of interest here, for example, in terms of diabetes as a comorbidity and various other factors of interest, but not available over this period of time. Now, more than 80% of all of these cases were pulmonary TB, which I think is important just for us to note. Some of that will certainly be because of the relative ease of diagnosing pulmonary TB versus extrapulmonary TB, particularly in a Papua New Guinean cross-border setting. It does mean, though, that all of what we're presenting here is based on data where largely culture confirmation, but at least lab confirmation of MDR TB was present. And so when we look at the more detailed drug susceptibility profiles of these cases, you can see that still a relatively small proportion of them were fluoroquinolone resistant, and only 4 XDR TB cases diagnosed over this 15-year period. In terms of the management that was received, in a lot of ways, pretty typical, I think, for this period of time. So almost all of these cases started on first-line therapy, and then after MDR TB was later diagnosed, usually on phenotypic drug susceptibility tests, moved on to MDR TB management. There was an average of about a month and a half between the diagnosis and, between initiating first-line therapy and initiating definitive therapy for MDR TB based on those susceptibility tests. But you can see quite a long spectrum there, with some people where the MDR TB diagnosis was known before treatment was started, and others who were treated for long periods of time for drug-susceptible TB before an MDR TB diagnosis was established. Fitting with the WHO recommendations over this period of time, there was an average of 5 drugs per person started on MDR patients in Australia. And I'll just present some data here that focuses particularly on the Australian cohort rather than the PNG based cohort, because there are some differences seen there. Not the intended treatment duration, but the actual treatment duration that was given was a median of 20 months. And for basically everybody in that cohort, if fluoroquinolone and injectable susceptibility was established, they were used universally. Quite a lot of differences, though, in terms of some other aspects of management, particularly directly observed therapy, where in some settings, particularly South Australia and the Northern Territory, we can see 100% of people receiving DOT throughout their treatment course, down to no use of DOT for MDR in Victoria, and varying proportions in other states and territories. Overall, 81% treatment success was reported in the Australian cohort. And if we compare that across the whole of the cohort in this 15 years, we see worse outcomes for people who were born in Papua New Guinea, who were identified as being HIV positive, and in our cohort, reported better outcomes in those who received injectable amikacin. Now, that last point is interesting because those of you who've been following updates in the WHO guidelines and the evidence basis for them over the last 5 or 10 years will have seen that that association with injectable amikacin has not been held up. In fact, quite the opposite in some of the large individual participant meta-analyses that more modern guidelines are based on. In our cohort, though, I think there's a significant association between the use of injectable amikacin and treatment access. So that's probably one of the major factors there that's influencing that as well. 7% of the cohort died, and there were no recorded cases of relapse after treatment for MDR TB in Australia over this 15-year period. Now, over the last 10 years, though, since this cohort follow-up finished, there's been quite a lot that's happened in international MDR TB management. New drugs, new regimens, some reflected in guidelines, some reflected in practice. And the question of just how much of this change has come into Australian practice over the last decade is a really important one. So when we look at what I can tell you now about the most recent cohort of MDR TB, 2018 is probably the most recent fair cohort to report on in terms of having outcome data. Nonetheless, it's also the most recent that I can tell you about because this is the most recent publication of genuinely national MDR treatment data. And this comes from the NTAC annual report for 2018. Now, still relatively low proportions of MDR TB, so about 2% of all cases, one of whom had XDR TB. Demographically, a change largely reflected because of policy around PNG-based treatment for MDR and some cross-border management issues that I suspect have been discussed already in this forum. Worth noting, I think, that 4 of the 7 Australian-born cases were Aboriginal and Torres Strait Islander people, and are really flagging, I think, a need for more understanding and investigation of how best to support Aboriginal and Torres Strait Islanders with MDR TB in Australia. And 83% treatment success. So really, what we can say from that, I think, is it's pretty static in terms of overall proportion of cases and treatment success outcomes, But I actually can't tell you very much more than that, because this is the extent of the published national data that exists. And some of the other questions that you have and I have around what medication regimens, what adverse effects to those treatments, some of the local epidemiology in terms of transmission and diagnosis, you know, and what we mean when we say that 17% of people did not have treatment success. Some of the details around that are not clear on a national level. And so for me, the question at this stage is, should we go back to efforts like Josh Francis's and do more cohort studies looking at what an updated profile of MDR TB in Australia is like, or should we actually just better develop our national standard reporting so that we have more systematic and timely access to this really critical data? More on this later. A couple of small points that always come up when we're talking about MDR TB in Australia. Cost is clearly recognized to be higher for MDR TB than drug-sensitive disease in all settings around the world, but the absolute magnitude of that changes a lot based on healthcare systems and approaches. We had a very brief look at a patient of ours some years ago and estimated that a healthcare level cost was in the order of $260,000, which included contact tracing, hospital admission, individual pathology tests, and the actual medications received, but didn't incorporate other really important factors such as patient level costs, impact on work and study, and a range of other economic factors that might be measured. This was based very much on an old MDR TB treatment protocol, particularly including injectable amikacin and long periods of hospitalization. And looking a little bit more in a theoretical sense, based on Victorian pricing at the time, this cost is a pretty typical sort of basic cost we might expect simply for purchasing the TB-associated medications for treating MDR TB under the 20-month WHO regimen, including, you'll see, quite a significant contribution from hospitalization, which includes hospital and the home costs for injectable amikacin. If we move forward into a more modern paradigm, we can see that with the drop of injectable amikacin, but still continuing on with the 20-month regimen, a significant fall in the associated cost there. This is, remember, whole of health care system costs, and the predominant saving, in fact, really the only saving, comes from reduced hospitalization over that period of time. Finally, if we are to look at the new all-oral recommendations for, I'm sorry, if we take those new all-oral recommendations and update them for this year, because of reducing costs of particularly things like bedaquiline, that cost continues to come down. And so currently, while MDR TB treatment in Australia certainly costs a lot more than drug-susceptible TB, those costs do continue to come down for a variety of factors that include guidelines but are not limited to them. So I wanted to say a couple of things about access to new drugs, because this comes up very frequently for me in a programmatic sense. And I think many clinicians and other actors in an Australian context don't have the full landscape about how we access new drugs and the different systems that underpin them. So first of all, these medications here, 100 milligram L-isoniazid, rifampicin, ethambutol for drug-susceptible TB, and some of the medications that we use at least sometimes for treating MDR TB are currently TGA approved for TB, that first line, and or TGA approved for other indications. So they are registered products. They're available here in Australia. There are other medications that we use very commonly, particularly pyrazinamide, but also a range of medications for use in MDR TB, which are not TGA approved for any indication, and so need to be gained through the special access scheme, which means that they can be imported under varying conditions for individual patient use. Over the last couple of years, Victoria and New South Wales have participated in a bulk purchase from the Global Drug Facility for pediatric fixed drug combinations. So that's been a fantastic initiative that Ellen Donnan has led, which has meant that over the last couple of years, we've had access to these medications which would otherwise not be routinely available in Australia. And so I've been able to start using these really important medications for improving quality of life in children who are on active TB treatment and also, to a growing extent, latent TB treatment. Now, coming into some more challenging space, we're going to have a lot of discussion about drugs like protominid. So protominid is not registered commercially, and so currently a pathway for access may be through a compassionate access program. However, as it becomes registered in other jurisdictions, it may also become available for incorporating under the special access scheme. I think it's worth, actually, no, I'll move on, I'll come back to this in a second. And finally, in terms of some of the other blue sky horizon treatments that we might have, there's certainly some interest in other non-tuberculous mycobacteria and potentially in MDR and XDR TB, thinking about the impact of phage therapy. And again, these are not registered commercially and would need to be used in Australia either under some form of a compassionate access program or as part of a clinical trial with the CTN scheme administered by the TGA. Now, I just want to say a word or two about the special access scheme, because we often get the message that these drugs, most of the ones that I just listed, are available in Australia because they can be got under the special access scheme. What I really want to highlight are two things. The first is that individual patients need to access medications through the special access scheme. And so it does mean that there can be some delays in accessing these medications depending on the category of access because of the need for paperwork, because of sometimes the need for ordering medications for a specific person and having them brought into the country if not already available. What's really critical for me, though, is that most of the medications that I've described are standard treatments for TB being used around the world, yet when we sign special access scheme forms to get these medications for our patients, we really have to communicate to them that they are unapproved therapeutic goods, and there is a significant degree of personal responsibility that prescribing health practitioners take for that. My view as both a clinician and a program director is that I think these responsibilities would be better borne by schemes like our TB programs, like our TGA, like other sponsors, rather than individual practitioners for a range of reasons that I'm happy to talk about with anybody, but really moving away from the need to access medications in the special access scheme would be advantageous for a range of reasons. And there are some things that are genuinely experimental. So if we are going to use phage therapy, for example, that should be in the context of a clinical trial, most likely, but if not, at least, well, it should be in the context of a clinical trial. But for a medication like pyrazinamide that has such a long and established history of use, having an individual clinician effectively telling a patient that it is experimental or similar, I think is inappropriate. And this, I think we've talked about, but really looking for alternative sponsors to take on some of those responsibilities and an increased role in surveillance of adverse effects and use and access would be desirable. Okay. There are some barriers to that, though, and we'll be familiar with the commercial barriers that stop commercial sponsors from registering medications, for example, like pyrazinamide, where there would be little profit to be made, but $250,000 application fee for registering a product or changing its indication to the TGA. So there are some barriers and some, I hope, creative thinking in this space that needs to be adopted. Finally, I think that beyond just talking about what medications we can make available, we need to think creatively and strategically about the kinds of supports that people affected by MDR TB in Australia need, and we have the capacity to provide. things that I list here, routine financial support for people who have MDR TB, individual and group-based psychology sessions, peer support groups, nutrition support, pulmonary rehabilitation. I think sometimes we look at things like this in an Australian context where we get used to our limited local services and we think that these sound beyond what we can provide. But the reality is that all of these things are provided routinely in different, frequently low resource settings. And I think we need to get serious about how we can leverage the opportunities that we have here in Australia to provide the best individualized care for patients that we can across a whole spectrum of things, not just the right drugs. So what do we need in MDR TB in Australia now? There's currently work to develop and update guidelines for MDR TB management in Australia to try to improve both transparency and uniformity of treatment across the country. Uniformity is a useful thing in terms of our structured approaches and our reporting, but we also need to be thinking about how to individualize therapy. That starts with better monitoring and evaluation, understanding what side effect profiles there are being experienced in our patients and what we need to support them towards better clinical outcomes. Now, I won't say anything more here, knowing that Vitaly is coming up next to talk about the impact of whole genome sequencing in terms of guiding therapy. But I think it's certainly part of a package that includes probably therapeutic drug monitoring and a range of other things for us to think about how we can individualize therapy as well as possible in a way that is transparent and focused on getting the best clinical outcomes for individuals affected by MDR TB here. So with that, I will stop. Thank you for your time. I clearly can't take any questions, but I'd be very glad to have emails or follow up with you afterwards. Thanks.